recognizing that this is one of the first talks, and you guys are all probably experts on this, but just level setting so we're all on the same page. Cystinosis, in sort of distilling it down to sort of the basics, is a problem with the lysosomes. So we know that an individual with cystinosis has 2 non-working copies of the CTNS gene. Because there isn't a working copy, a person with cystinosis can't make the protein cystinosin. Without cystinosin, cystine gets trapped in those lysosomes. And those are like the recycling centers for our cells. They break down big molecules and then into little pieces that our cells can use. And so the cystine builds up in our lysosomes and causes problems. And we also know that cysteamine gets into the lysosome and then helps cystine be chemically modified and get out. So I wanted to sort of just go through a little bit of that basics that you guys know and then zoom out. So we talked about one cell. So we all know that cystinosis affects almost every part of our body: kidneys, eyes, GI tract, but it also impacts many different organs, and that's all because we have the same DNA in each of our cells. And so with that, I will turn it over to Dr. Thoene.
When you teach a introductory service course, it seems to me always important to get the history. So Beth and I agreed that I would do the history and she will do the important parts. But I did want you to realize that cystinosis, though it's rare, is not as rare with publications as you might think. And so this shows you the publications on cystinosis per year, starting way back in the early 1990s, but up to 2020, now we're getting 60 to 80 publications a year. So with persistence, it's becoming well known to a variety of scientists, not just of those like myself and Dr. Ames, who study cystinosis almost exclusively. Now, I wanted to just cover the history there. And the first one in the early 1900s, what's the date on that? Anyway, and then we had, can I see it on the, I had the same problem yesterday. I can't see the slide well enough to read it. Abderhalden described cystinosis in the 1920s. And then we had a progression of people studying the various aspects of cystinosis, including the Fanconi syndrome, and describing it as something like glucose, but not with elevated blood sugar. The distinction between cystinuria and cystinosis is important, and you as parents should know that, because sometimes they still get confused by people that haven't read, people meaning medical people who haven't read very clearly. And cystinuria is another disease that's characterized by forming cystine crystals, but that's extracellular, and it causes kidney stones, but nothing else bad, not a systemic disease like cystinosis. You may hear of the swan neck deformity. This is the first photograph of one published, and you can see how this is one of the thousands of renal tubules cells that form the tubule that takes urine from the glomerulus to the ultimately to the bladder in urine. And when that necks down, it eventually breaks off. And when that happens, then you have, when that happens to all of them, you have kidney failure. And then there's the description of lysosomal localization that Beth just mentioned, and the fact that cysteamine was actually discovered in 1976 and discovered that it gets cystine out of lysosomes. The transport gene, Beth has already covered. And so with that, I will leave the history, and you can get on to the meat of Cystinosis 101.
Okay, awesome. And so we've already, again, had a little bit of an introduction, but so when we think about a genetic condition, it's really important to understand what DNA does. So DNA, we each have 2 copies of every gene. We get one from our mom and one from our dad. And those chunks of DNA are then used to make a message referred to as RNA. So the DNA stays inside our nucleus, it gets turned into RNA. The RNA goes out into the cell and is turned into that protein that does the actual work. So in the case of cystinosin, it helps get the cystine out of the lysosome. This DNA to RNA to protein is foundational to understanding genetic disease, and we call the central dogma of biology. And so when we think about how can a person get a diagnosis of cystinosis, we oftentimes rely on measuring the cystine levels and saying, oh, it's high, this makes the diagnosis. But more commonly, I would say kids are actually getting diagnosed with genetic testing. And so actually just looking at those chunks of DNA and finding differences that are responsible for cystinosis. I will also just put in a tiny plug that there's a separate type of genetic testing called carrier screening. So that's usually genetic testing done before or during a pregnancy, and that can sometimes tell a person if they are a carrier of cystinosis and potentially inform risk for a future child. And so one important thing to understand about the genetics of cystinosis is how it's inherited. So we would say that cystinosis is an autosomal recessive condition. And that means that both of those copies of the gene are not working. We have some genetic conditions where even one non-working copy causes genetic conditions. Those are dominant, but cystinosis is recessive. And so as this picture shows, each of the parents in this example cartoon is a carrier. So that blue side basically says that it's a non-working copy. And so every time a child is conceived, it's literally a 50-50 chance whether the working copy or the non-working copy is passed down. And so because of that random chance, 25% of the time, a child inherits both of the working copies. 25% of the time, a child would potentially inherit those two non-working copies and have cystinosis. And then the other 50% of the time, they have one non-working copy and one working copy and are also carriers. Okay, and I actually was not expecting anyone to have, to already have a genetic test report presented today, but I did want to explain what a genetic test result looks like because I think it's really common that families are having genetic testing now. And so this is really like a geographic coordinates of where a difference in the DNA is. And so for this example, again, just taking some of my own patients, this individual has two different changes in the CTNS gene. And so if you imagine that a gene is just a string of letters, at the 1015th letter, most people have a G, but this individual has an A. And that one tiny letter difference causes a difference in which amino acid is included in the protein, and that one amino acid makes the protein not work. And so that we've seen from multiple times in many other patients with cystinosis, so we would consider that pathogenic or disease-causing. And then the zygosity refers to whether it's one copy, heterozygous, or as we can see in this example, homozygous, meaning two copies. Another really common variant in CTNS is, in the gene is a partial deletion of almost most of the gene itself. And so multiple of my patients are actually homozygous, so they have two of those partial gene deletions. Okay, and I have the privilege of taking care of kids with cystinosis and adults with cystinosis, and the adults are always like, well, I've been diagnosed with cystinosis for years. Why should we do genetic testing now? And I think it can help us guide treatment, hopefully in the future. Again, thinking optimistically towards the future, I think there will be gene therapy at some point that's approved and is covered by insurance And insurance is definitely going to want you to have a genetic test result proving you have cystinosis before they're going to pay for gene therapy. But I also think it's really helpful to frame in the context that the CTNS gene is just one gene of 20,000. And so those other, 19,999 genes are doing different things. And I think that that's an important reason why cystinosis is different for different people, is that there are probably modifying genes. All right, so I want to just spend the last few minutes talking about how our understanding of genetics is framing new treatment options. So as we'll hear from Dr. Thoene in a little bit, that small molecules like taurine might be helpful. And then we'll talk about a couple different forms of genomic therapies. So the first type of genomic therapy is cell-directed ex vivo gene therapy. The main idea is that you take some cells outside the body, you use genetic techniques to fix them, and then put those cells back in. It's exciting because this is a way of creating a lasting difference in the DNA that hopefully gives a working copy of the CTNS gene. We have used cell therapy for many different applications already. So we've used it for cancers. Kymriah is a blockbuster in the world of treating leukemia. And then other genetic blood disorders have been successfully treated with cell therapy. Another form of gene therapy is in vivo. That means taking a working copy of the gene and putting it into the body. We often do this with non-infectious viruses, so viruses that can't cause a cold or other symptoms, but really is a way of giving a working copy of the DNA into the cells. In vivo gene therapy can do a really good job targeting hard-to-reach parts of our bodies, like brains or eyes or muscle. It can treat the whole body at once, and we know that this works really well. So Zolgensma has revolutionized the way we take care of kids with spinal muscular atrophy. Usually that is a genetic condition that babies tend to pass away between 1 to 2 years of age. And now we're seeing kids who are doing fantastic things because of gene therapy. We also know that gene therapy can cure genetic forms of blindness. One of the newer forms of genomic therapies is antisense oligonucleotides, or ASOs, because that's a mouthful. And basically that is a tiny piece of genetic instruction that helps the protein work better. This can be targeted to an individual's mutation or genetic difference. And so one example of this was actually at the University of Michigan. There are 2 girls who had a genetic condition called Batten disease, and researchers at the University of Michigan actually developed ASOs exactly to their genetic difference and are treating them with this ASO. One thing that's nice about it is that it actually doesn't change our DNA, but it still helps improve the function of the protein. We also use ASOs for the treatment of SMA, and that has also been really, really successful. And then the last form of genomic therapy that I think is really exciting is this CRISPR that people have heard about. And that is really the best, I think, way that so far we have to go in and fix a non-working copy of a gene. So it's almost like genetic surgery. I think it's also important to mention that CRISPR was actually discovered in bacteria as part of their immune system. And researchers were like, oh, let's explore these bacteria. And through decades of work, they were able to say, gosh, this is so useful, and ended up being able to treat humans with genetic conditions. So it's kind of like one of those things, you never know where a scientific discovery is going to sort of take you. But this CRISPR is really exciting and got a lot of press earlier this spring because a baby at CHOP actually received CRISPR therapy to correct his metabolic condition. This is a picture of KJ and his family and the doctors who created that CRISPR, and he's doing incredibly well. All right, so this is my summary slide. I know that we've kind of gotten off on our timing, so just briefly, I think the big thing to take away is that, we're sort of standing on this cusp of gene therapy, and there's so much hope for the future. There's so many different ways that we have to take non-working copies of DNA and get them working again, and so I'm just really excited about that. Also, I have a genetics fellow who's really interested in hearing about adults with cystinosis and how they view their healthcare having changed after the pandemic, and like using portal messages and video visits. So if you're an adult with cystinosis, my fellow would be incredibly grateful if you would take her survey. Thank you to Dr. Thoene. He has taught me everything I know about cystinosis. I probably don't know as much, I definitely don't know as much as him, but he's also let me take care of his patients, and that's an incredible honor.